Morning, everyone. Today, in our continuation of the urology exam preparation training, we are discussing intermediate and high risk prostate cancer. We had wonderful discussion on organ confined low risk prostate cancers discussions in the last session. We have our trainee, and Anish is leading the show. Floor is yours, Anish.
Thank you, Mr. Sanshikaran. We had good feedback from the last session. One of the additional things that I had to mention during the active surveillance, we now have the BOUS information leaflet for active surveillance to counsel the patient. And that was published 2 months ago in July 2021. So it would be worthwhile to add that as well when we counsel the patient for active surveillance. I found it one of the difficult questions when it was asked in the exams. So this will come handy. So we will move on to the next part. So today we are going to discuss the intermediate and high risk prostate cancer, locally advanced and metastatic prostate cancer. So is it all right for us to start now?
Yes, please.
Yes, thank you so much. So imagine that you are in the MDT. The MDT proforma in front of you says that the case that's going to be discussed next is of a 65-year-old fit and well gentleman with no comorbidities. He has no family history of prostate cancer. His IPSS is 9+3. He underwent a local anesthetic transperineal biopsy for a PSA of 9. His MRA was PIRADS 5 anterior zone, 60 cc prostate with a PSA density of 0.15, and MRIs as usual is reported as if cancer is found T2 and 0 MX. So the pathologist is going to discuss the pathology now. So what are the things that you want to know in the pathology of the prostate biopsy?
So in the biopsy, I want to know if there is any prostate adenocarcinoma in any of the cores, the number of the positive core, maximum core length, and the positive ones. I want to know the Gleason grade and the grade group. I want to know if there is any tertiary score, and also I want to know if there is any perineural invasion.
So the pathologist says that the biopsy shows adenocarcinoma, Gleason 3+4, grade group 2 in 4 out of 4 of the targeted cores and 4 out of 24 of the systematic biopsies. There are more than 50% core involvement in 3 cores. So what are the options for him that you are going to discuss in the MDT?
Yeah, so the biopsy was 4+3 Gleasons.
Sorry, and so the biopsy was Gleason 3+4, grade group 2.
Yeah.
In 4 of 4 targeted cores and 4 out of 24 systematic biopsies. So total of 28 biopsies, 8 cores are positive.
Yeah, so this patient, according to the risk stratification, he's an intermediate risk prostate cancer because of the Gleason 7 prostate cancer. So we will discuss his histology and the MRI in the MDT meeting. There is no need to arrange for a bone scan for this patient. And then I think from the MDT, we'll get the recommendation of active treatment according to the NICE guideline in the form of either radical prostatectomy or radical radiotherapy. So I will see the patient following the MDT accompanied by the oncology nurse, and I will explain to the patient the result of his investigation and the recommendation from the MDT.
Perfect. So you said that we don't need a bone scan. So is there any levels of PSA that can predict the bone scan positivity?
Yeah, usually the possibility of having a positive bone scan increase with PSA more than 20. So the current indication to have a bone scan is if the PSA more than 20, or if the clinical or radiological staging suggests T3 disease, or the patient having a group grade 3 or above. And also if the patient has symptoms suggestive of bone metastasis.
Well done. So just want to add only one thing. You are absolutely right. It is more, the bone scan is more positive when the PSA is more than 20. If you want to put the numbers there, for a PSA of less than 10, the chance of bone scan positivity is around 2%. Between 10 and 20, it is 5%, and more than 20, it is 16%.
Okay, thank you.
And so the MDT decides to give all the options to the patient, and more emphasis on the active treatment. So how you are going to arrange for the counseling of this patient?
So I will see the patient in the post-MDT clinic accompanied by the oncology nurse. I will explain to the patient that he has intermediate risk prostate cancer, which seems to be localized. Therefore, we recommend active treatment to give him the best chance of a cure. And the active treatment will be in the form of either radical prostatectomy or radical radiotherapy. Because of the prostate volume, which is more than 50 cc, the patient is not a candidate for brachytherapy. I inform the patient that there are other treatment options, which is still in the setting of clinical trial, including HIFO and cryo. I'll explain to the patient about the pros and cons of radical prostatectomy, the robot-assisted radical prostatectomy. So I will explain to him the aim of the procedure, which is to remove the cancer and to preserve the function as much as possible. I'll explain that nowadays 80% of these procedures done with the help of robot. I will counsel him about the possible complication, which include complication related to the general anesthesia, like cardiac, respiratory, or DVT in about 5 to 10%. The usual complication associated with surgery, like a bleeding, infection, need for transfusion, also in about 5 to 10%. Risk of rectal injury in 5% of the patient. The most significant one is sexual dysfunction and lack of ejaculation, which happen in about 40 to 60% of the patient, and urinary incontinence, which is to start with maybe experienced by 50% of the patient. However, down the line, with the help of pelvic floor exercise, only 5 to 10% will have a significant incontinence, which means that they need to use more than one pad per day by the end of the year. There is also a low possibility of having a positive margin. So I'll explain all that to the patient, and I will support my counseling with a BOWS leaflet.
Okay, amazing. And it is always nice or sweet to bring the term joint oncology clinic, especially when you counsel a patient for intermediate risk prostate cancer. But otherwise, yeah, you covered all the points.
Okay.
So you said that you will, from your side, from the surgeon side, you will counsel him for the radical prostatectomy. So what is the evidence for radical prostatectomy in intermediate risk prostate cancer?
So the evidence came mainly from the Scandinavian Prostate Cancer Group 4 article in 2014, which is an 18-year follow-up for a patient to have a radical prostatectomy versus watchful waiting. And it showed there is an absolute risk reduction of cancer mortality by 11%. And when they apply that specifically for a patient with age less than 65, the benefit is even more, with absolute risk reduction of death is about 19%, and number need to treat dropped from 8 to 4.
Okay.
So this was supportive for the radical prostatectomy. Another study is the PIVOT study, which is a US-based study, which failed to recruit more than 700 patients only. And it showed that there is, overall, there is no benefit regarding the cancer-specific or overall survival from radical prostatectomy compared to watchful waiting. However, in further analysis of the data, a patient with high risk prostate cancer will have some survival advantage.
Okay. All good regarding the SPCG4. In the pivot, only the last sentence, because the borderline benefit in the subgroup analysis was most marked for intermediate risk. And the outcome was no benefit for low or high risk. So that is the only thing in the pivot.
Okay.
I'm quoting it from the EAU 2021. But we had to go back and review because I think you said that its pivot is borderline benefit in the high risk, isn't it?
Yeah, that's my understanding, that the high risk people will have some survival benefit.
Yeah. What's given in the guidelines is there's borderline benefit for intermediate risk. So it might not be a big trouble, but the thing is that for high risk patients, we do robotic prostatectomy only as part of multimodality treatment.
Okay.
So possibly, and when I look back, even the in the original paper of the pivot, I have marked it like it's an intermediate risk disease that has got borderline benefit.
Okay.
And what about PROTECT trial?
So the PROTECT trial is a trial which compare between just monitoring of the PSA versus radical prostatectomy versus radical radiotherapy. And after a 10-year follow-up, they found there is no significant difference in mortality between all the arms. And there was about 10% death, which is comparable in all the group. However, the active treatment group, which is the radical prostatectomy and radical radiotherapy, they showed a 50% reduction in the risk of progression and metastasis. And both surgery and radiotherapy results were comparable.
Excellent. That's really good. So moving forward, one of the questions is there any role for neoadjuvant treatment prior to radical prostatectomy?
No, at the moment, the guideline doesn't recommend any neoadjuvant treatment. There was some trial about neoadjuvant hormonal therapy before radical prostatectomy, which showed reduction in the prostate volume and also a reduction in the percentage of positive margin. However, this was not translated into a survival benefit. Therefore, it is not recommended.
Very good. Comparing the options or approach to the surgical options, you said that mostly in UK, everything is done by robotics now. But is there any comparison between robotic versus laparoscopic versus open surgery?
Regarding the oncological outcome, all of them are comparable. However, the minimally invasive procedure, which is laparoscopy and the robot-assisted radical prostatectomy, associated with less blood loss, less pain after the procedure, and early recovery with shorter hospital stay. These are the advantage. On the other side, this minimally invasive procedure usually take longer time and they are more expensive due to the cost of the disposable.
Well done. Coming to the lymph node dissection, so what are the indications for lymph node dissection in radical prostatectomy? Will you do it for all patients or will you do it for only selected group of patients?
So lymph node dissection is usually indicated for patients with intermediate and high risk prostate cancer undergoing radical prostatectomy. And it needs to be the extended lymphadenectomy, which is going up to the bifurcation of the aorta with inclusion of the internal and external, internal iliac, external iliac, obturator, and presacral lymph node.
All right. Does any nomograms help you to decide?
Yes, I'm aware of the Parton's nomograms, which was derived from thousands of radical prostatectomy specimen. It helps to detect the the pathological stage following radical prostatectomy, and also the possibility of having positive surgical margin, similar vesicle involvement, and the lymph node involvement. And it is mainly depend on the clinical criteria like the PSA, the Gleason grade of the patient, and the age.
Okay. Yeah, well done. Only a couple of things to add is there's a 5% cutoff recommended by the EAU regarding the role for lymph node dissection in during radical prostatectomy. And there is this update on a new 7% cutoff after the introduction of MRI targeted biopsy. So just to add those 2 points.
So sorry, what do you mean by the cutoff?
Yeah, so when you use the nomograms, how it helps in deciding the lymph node dissection is if the nomogram shows, if you are using a Parton's nomogram or a Briganti nomogram, there is one called as MSKCC, and there is a Roche formula. So these are the 4 type of nomograms that are commonly used. There are no difference when we use any 4 of these. When we use the nomogram, and if it predicts that the chance of involvement of the lymph nodes are more than 5%, then it is an indication for a lymph node dissection.
Okay, yeah, I'm aware of in Briganti one, the threshold is 7%. Yeah.
Yeah, and it was traditionally the teaching was 5%, but recently because of the MRI targeted biopsy, they have increased that target to, that level to 7%. So if the patient had an MRI targeted biopsy, the cutoff for the lymph node dissection is 7%.
Very good. Okay, thank you.
Thanks. And regarding, we can always say that we will do it for high risk disease. And it is the intermediate risk disease that helps, where these nomograms helps to decide on the lymph node dissection.
Okay.
Ahmed, can I ask a question? Yeah. Why do you think they increased the cutoff from 5 to 7% whenever we are using MRI targeted biopsy? What is your understanding?
So because sorry.
Yeah, go ahead.
No, for Ahmed.
Sorry.
For Ahmed.
Yeah. So my understanding is that now we have a better representative sample from the prostate cancer with a better histological staging rather than any staging like before with the trust biopsies or without the MRI target biopsy.
Yeah, it is not only better, the correct word is a kind of upgrading. Say, for example, in the previous cohort where we haven't used MRI for the biopsy, if the biopsy is say 3+3 or 3+4 in 2 patients, if we do an MRI targeted biopsy, what's happening is the 3+3 can become 3+4. MRI will only upgrade a patient's histology, Gleason score, volume of involvement, everything will be only upgraded. Since there is a upgrading, if you use the nomograms which were in the age of just normal biopsies without using MRI, you will be upgrading all the patients which were previously like possible 3% chances easily into 5% chances. So your lymph node resection requirement will be very high. So that's why it is increased to 7% to match with the upgrading happens with the MRI guided targeted biopsies.
Okay, thank you very much.
The reason why I interfered is if you understand this, number one, it's very easy to reproduce in the exam. And the values 5 and 7 that we have to mug up, and that will come as you present again and again in the forum.
Okay, thank you.
Thank you, Mr. Nashagan. You counsel the patient regarding the surgical part, and I know we don't counsel much regarding the radiotherapy part to the patients in the joint oncology clinic. Those patients are seen by our radiology colleagues, but we'll go through the basics of radiotherapy. So, do you know the types of radiotherapy that are available at present?
Yeah, so the types of radiotherapy used for treatment of prostate cancer are the external beam radiotherapy, the low dose rate brachytherapy, and the high dose rate brachytherapy.
All right. And it is better to add one more thing, proton therapy, even though it is not used widely. It is used in some centers, so we can add the proton therapy as well.
Yeah, it's a new.
Yeah, it's a new one, but not widely used. Yeah. Coming to the protocol of external beam radiotherapy, do you know what is followed in UK now?
Initially, the external beam radiotherapy was given in accordance with the NICE guideline in 74 gray, which is usually fractionated into 37 sessions. However, the CHIP trial showed non-inferiority for the new protocol of 60 gray, delivered over 20 sessions. I think most of the center now, they are following the 6-degree over 20 session.
6-degree or 20 sessions, isn't it?
Yeah.
Good. Can you tell me some of the contraindications for external beam radiotherapy?
So the main contraindication is previous history of pelvic radiotherapy. If the patient is having an active inflammatory bowel disease, and if the patient is having significant lower urinary tract symptoms.
Perfect. What's the role for ADT in the scenario for radiotherapy?
So there are a few studies which show that there are additional benefit from giving hormonal treatment prior and after the radiotherapy. And the NICE guideline currently recommend a new adjuvant hormonal therapy before radiotherapy for at least 3 to 6 months. And then following that, the radiotherapy will be continued for a total of 6 months if it is intermediate risk of prostate cancer. If it is a high risk, then it's recommended to extend it up to 3 years. The evidence comes from the BOLA study, which showed an improvement in the progression-free survival and reduction in the biochemical relapse following radiotherapy when it's combined with hormonal treatment.
All right. So the BOLA et al. Proved that the disease-free survival is better, isn't it?
Yeah.
If you want to put the numbers, again, there was a real difference in the disease-free survival. It was between 74 with ADT versus 40 without ADT.
Yeah.
Because in your Viva, BOLA et al. Study is one of the questions that is most frequently asked. So coming to the brachytherapy, what are the types of brachytherapy are you aware of?
So we have the low dose rate of brachytherapy and the high dose rate. In the low dose rate, there is an implantation of seed into the prostate under a transrectal ultrasound guidance. And then these seeds will emit radiation to a short distance. So this will give a high dose of radiation to the prostate and minimize the dose of radiation to the nearby organ, mainly the bladder and rectum. Mainly we use the iodine 125 or palladium 103 on that. And the main indication for low dose rate brachytherapy that the prostate should be less than 50 cc in volume. Because if it is a bigger prostate, it will be difficult to implant the seed properly. And also the patient shouldn't have a significant lower urinary tract symptoms or previous history of TURP, as this may increase the chance of urinary incontinence and significant loss following the procedure. Also, the patient shouldn't have a previous pelvic radiotherapy. So these are the main selection criteria for low dose rate brachytherapy. It can be given alone for the low risk prostate cancer, and sometimes is combined with external beam radiotherapy for the intermediate or the high risk prostate cancer. It may cause some complications similar to radiotherapy, but usually less significant. So it may cause as well significant lots. It may cause some hematuria and cystitis. It may cause some proctitis. It may be associated with erectile dysfunction, about 40 to 50% of the patient, but the rate of incontinence is less than radiotherapy.
What about the radiation protection for the patient and carers when they use low-dose brachytherapy?
So it is recommended that young children and pregnant lady to be away from patient following brachytherapy for about 2 months until the emitted dose of radiation come down. And those patients usually they are asked or advised to avoid any pregnancy if it is possible, if they are young enough, and to use some condom during sexual intercourse in case any of the seeds will be passed with the ejaculation.
Well done. And regarding the high dose rate brachytherapy, what is the isotope used?
It is the iridium but I'm not sure of the anatomical number, but they use the iridium. And in this one, there is no permanent seeds. There are tiny plastic tube, which are inserted under guidance, under general anesthesia, into the prostate. And then this may be done once or twice, and this will deliver a high dose of radiation.
Well done. And iridium 192 is used, isn't it?
Yeah.
Well done. And are you aware of the term PSA bounce? Because you might face it when you review the patient in the outpatients after the radiotherapy. So what is PSA bounce?
So the PSA bounce is an increase in the PSA following an initial reduction. It usually happens around 9 months following external beam radiotherapy, and it may take more than a year in case of brachytherapy. And the PSA increase shouldn't increase more than 1.5, and usually it is transient, and then after that we return back to the another level. So for this patient, I will just suggest a close follow-up.
Monitor. Okay, well done. Coming to the other role of radiotherapy, what is the role of radiotherapy after radical prostatectomy, or the post-operative role of radiotherapy?
Yeah, so for patients who have a radical prostatectomy and the histology showed a positive margin or seminal vesicle disease, which indicate a locally advanced disease, for this patient, there are many studies which should benefit of adjuvant radiotherapy. However, there is some controversy about the timing of radiotherapy, whether to give immediate external beam radiotherapy or to wait for the progression to happen, and then we can give a salvage radiotherapy, because it is known that when there is the biochemical relapse of the PSA, it will take about 8 years to be symptomatic and associated with metastasis. And then from the time of metastasis, there is a median 5 years up to stage of death. So the argument, some people argue that just to observe it to start with and then to start radiotherapy later on. However, I am aware of a BOLA study which showed a significant improvement in the progression-free survival and reduction in the biochemical relapse if we use the immediate adjuvant external beam radiotherapy, which improve the progression-free survival from 52 up to the 52 with the delayed one, up to 72% with the immediate external beam radiotherapy.
Right. So that was the evidence that we were following previously, but after the Radicals trial, because that is the largest trial for postoperative radiotherapy in prostate cancer, the practice has moved now to not offer immediate radiotherapy, because the Radicals found no difference in the disease recurrence at 5 years between men who routinely had that radiotherapy shortly after the surgery and who had the radiotherapy later. So now we are following the outcome from the Radicals. So in the exams, we can say that currently the standard that we follow is no immediate postoperative radiotherapy, even if the margin is positive. We follow it up, and if there is clear evidence of recurrence or other factors that comes into play, then only the radiation oncology will decide on the radiotherapy.
Yeah, so this is also the standard from the NICE guideline. Exactly. To observe the PSA closely, and when the PSA is between 0.5 to 1, preferably before it is 1, to offer the radiotherapy.
Excellent, yeah, exactly. So regarding the follow-up after radical prostatectomy, so how would you follow up after radical prostatectomy?
So I will see this patient after discharge from the hospital. She should return back for a trial without a catheter, usually in about 10 to 14 days. Mm-hmm. And after that, I will arrange for the first visit to happen around 6 weeks. I will check for any early post-operative complication in the patient. I will inform the patient about the histology, the grade, the stage, if there is any positive margin or a lymph node. And also I will make sure that the patient is following the pelvic floor exercise, which we already started with him before the surgery. I'll make sure that the patient is having PD5 inhibitors as a part of the penile rehabilitation. I will see the patient with the oncology nurse, definitely. We give him some contact details in case he needs any help or advice. And after that, I will see the patient in 3 months from the surgery. At this point, I will arrange for the PSA to make sure that the PSA is dropped down below undetectable level.
What is the expected PSA level after a completed radical prostatectomy without any positive margins?
Yeah, so it should be very low at less than 0.02.
Okay. And yeah, especially with the super sensitive PSA, it can go up to that level. And when you do the follow-up with the PSA, what is the cutoff when you suspect biochemical recurrence?
So there are many definitions for biochemical relapse following radical prostatectomy, but I'm following the one is that when PSA reach 0.2, at any point, this is regarded as a biochemical relapse.
And what will be your plan of management when the PSA reaches 0.2?
Yeah, so when the PSA reach 0.2, usually the patient will have a median survival of about 8 years before any symptoms or metastasis will start. So there's a controversy again about whether to offer an immediate radiotherapy or not, or we will wait. So the option for this patient, I would say, either just to continue observing the situation. We can start hormones when the PSA start to increase significantly, but if the patient is quite fit and he is keen to have a curative treatment, then we will just continue following the PSA very closely. And when the PSA reach 0.5 to 1, I will offer him radiotherapy. There is some problem about staging of this patient, because usually when the PSA is very low at this stage, bone scan and CT scan are not expected to be positive until the PSA is around 7. So some of the centers, they are using PET scan for detection of any metastatic focus of the prostate cancer. Other centers, they are using the whole body MRI. But I think most of the centers now, they are using the PSMA test, PET scan.
And what are the recommendations or recent recommendations for the cutoff value of PSA for doing a PSMA PET scan?
I think it's the same, should be less than 1 when it is between 0.5 to 1.
Yeah, so in the latest EU guidelines and also in 2020 as well, the cutoff at which PSMA PET has to be done is when the PSA is more than 0.2. So if it goes to more than 0.2, we can do a PSMA PET if available.
Good.
So we will move on to a different part of the discussion now. So we will concentrate on the hormone therapy, ADT mainly. So what are the options of hormone therapy are you aware of?
So the aim of hormonal treatment is abolition of the testosterone. We know that 90 to 95% of testosterone produced from the testis and about 5% produced by the adrenal gland. So we can have this controlled either via surgical castration in the form of bilateral subcapsular orchiectomy, or medical castration in the form of gonadotropin releasing LHRH agonist, LHRH antagonist, and anti-androgens.
All right. What is the because the questions that I'm going to ask next is the one that I faced in the exam, in the viva exam. So what is the active form of testosterone?
The active form of testosterone?
Yeah.
Yeah, it's mainly the more active form of testosterone is the dihydrotestosterone, which is converted by the effect of the 5-factor reductase, which convert testosterone to the dihydrotestosterone, which is 10 times more active than the testosterone.
Well done. And how does it act in the cell, the dihydrotestosterone?
So the dihydrotestosterone will attach to the androgen receptor inside the cell, and then there will be a translocation of the complex into the nucleus. And then inside the nucleus, they will start producing a new coded proteins, and this will support the growth of the prostate cancer cells.
Well done. So you said about the LHRH agonist and LHRH antagonist. Are you aware of any recent oral GnRH antagonist?
Antagonist? No, I'm not aware. I know that all of them given mainly by injection.
Injections, yeah. It's not been available yet, but the FDA has approved one called as Relugolix, RELUGOLIX.
Okay.
Might not be asked the exam, but if it is asked, we can always say that there is a new one in the market, but it is an oral one. That's a plus point of Relugolix.
Very good. That would be great for the patient, yeah.
Yeah, exactly. And coming to the anti-androgens, how does the anti-androgens act?
So we have two types of anti-androgen. We have the steroidal and anti-steroidal anti-androgen, which are working mainly by competitive inhibition at the level of the androgen receptor. However, we have also the new or the novel anti-androgen like enzalutamide, apalutamide, and others, which act mainly inside the cell by inhibiting the nuclear translocation of the dihydrotestosterone and the androgen receptor complex.
Well done. So, for a patient with a suspected metastatic prostate cancer, what is your protocol to start androgen deprivation therapy?
So he is a metastatic prostate cancer.
Yeah, for metastatic prostate cancer.
Yeah, so for this patient, usually we start first by giving the anti-androgen because the most widely used medical castration form is the LHRH agonist, which will act by overstimulation of the pituitary gland to start with, and then after that there will be suppression. So it may associate with some flare phenomena. Initially, therefore, we need to cover the patient with anti-androgen. Usually it is started 1 week before the first injection, and then it can be stopped about 2 weeks following the first injection. This is especially important in patients with large volume metastatic disease, patient with spinal cord compression, and the flare-up may be associated with a significant progression of their disease. After the 2 week, usually from the injection, I will stop the anti-androgen and continue just with the LHRH agonist in 3 monthly or 6 monthly injections.
Well done. So when you counsel the patient for androgen deprivation therapy with LHRH agonists, how do you counsel regarding the side effects?
So I inform the patient that this medication will associate with some side effect, mainly in the form of hot flushes and sweating. It may associate it with some gynecomastia. It will affect his erection and libido. The patient also, his cognition and mood may be affected by the hormonal treatment. It may cause an increased risk for metabolic disease in the form of hypertension and diabetes. Patient may put weight, and there is a loss of the muscular mass and some osteoporosis in the bones as well.
Well done. That was a precise answer. Coming to the treatment part, what is the current standard of care for a newly diagnosed metastatic prostate cancer for a otherwise fit and well patient?
So the standard of care is just to give hormonal treatment in the form of LHRH agonist. However, we have evidence from the Stampede trial that if the patient is given an upfront chemotherapy or the new anti-androgen therapy, then there will be a survival benefit. Because my concern is that in this patient with metastatic prostate cancer, if we keep him only on the LHRH agonist, there will be a nice response to start with, but within 18 to 24 months, the patient will pass into the castration-resistant prostate cancer. And if we start the chemotherapy at that time, it will be less effective than when it is started as upfront.
And coming to the docetaxel, what is the mechanism of action of docetaxel?
So it acts by inhibiting it's a microtubule inhibitor, which inhibits the mitosis in the cell.
Okay. Are you aware the protocol of docetaxel, how it is given?
Yes, it is given in a dose of 75 milligram per square meter, given parenterally every 3 weeks. So usually it's given, I think, about 6 to 8 cycles.
And coming to when you see a patient on LHRH agonist who already had the docetaxel as well, when will you suspect castration-resistant state? Or I'll make it simple. What's the definition of castration-resistant prostate cancer?
So castration-resistant prostate cancer is a biochemical or progression of the prostate cancer in spite of castration level of testosterone. So in this patient, we need to make sure that the level of testosterone is at castrate level. And then if the PSA is continue rising, usually the definition, again, there is no agreed definition, but if there is a 3 successive rising of the PSA, at least 6 months apart, or there is a progression of his known metastasis, like discovery of a new metastasis or increase in the size of already present metastasis, then this patient regarded as a castration-resistant prostate cancer.
Yeah, I would highly suggest to, because possibly for the Viva, the couple of things that are asked in the CRPC scenario is one, the definition, two, the role of neuroagents, and possibly some evidence, but mostly it won't be asked to the level of the evidence, but definitely definition is important. So it is defined as a testosterone less than 50 if you're using the nanogram per deciliter, or less than 1.7. There are some suggestions that the PSA level should be, the testosterone level should be less than 20 because of the super sensitive testosterone available now. But for the definition purpose, we will put it like the castration serum testosterone less than 50, plus either it should be a biochemical progression or a radiological progression. And the biochemical progression is defined as 3 consecutive rises of PSA, at least 1 week apart.
Okay.
And there should be 50% increase over the nadir.
Yeah.
With an absolute PSA level more than 2. It's a bit difficult to say, but if you put all these things together, like 3 consecutive rise 1 week apart with the PSA more than 2. So there is 3, 1, and 2 in that definition. So if you remember 3, 1, and 2, it will be easier.
Yeah.
It's a biochemical progression. Radiological progression is easy. The appearance of new lesions.
Yeah, definitely.
So what are the treatment options for a patient with CRPC who already had docetaxel and ADT?
So in spite of docetaxel patients still having progressive disease, then we will think about giving abiraterone acetate or enzalutamide. There is,
metastatic cord compression in itself is a very important clinical scenario that needs to be discussed separately. We will discuss that definitely in our 10-minute Viva session, but shall we quickly discuss it for 5 minutes, if it's all right?
Yes, yeah.
So a couple of things. One, what are the red flags that you look for when a patient comes with suspected metastatic cord compression?
So I'm looking in the history for a new onset of pain, especially the pain coming at rest and pain coming in the night. If there's any radiation of the pain down to the lower limbs, if there's any new onset of symptoms like paresthesia or reduced sensation in the lower limb, and also if there is any change in the bowel habit like constipation or urine retention.
Okay. So how are you going to arrange the further investigations and care pathway for this patient?
So this is regarded as a urological emergency. So for this patient, who I suppose he's known already to have a prostate cancer. So for this patient, I need to see him on urgent basis. I will do a proper examination, looking mainly for any palpable bladder. I will examine the genitalia, examine the prostate, assess the rectal tone of the patient, and I will do an examination of the lower limbs in terms of motor and sensation with the reflexes as well. I will arrange for the patient to have some blood tests, including the PSA, and also I will arrange for him to have an urgent MRI scan of the spine, looking for any feature of spinal cord compression.
Okay. And if it shows any features of spinal cord compression, what are the treatment options that you're going to offer him?
So this patient should be started immediately on a high dose of steroid. Usually we give dexamethasone. 16 to 24 milligram, accompanied by omeprazole, gastroprotective, and then I will involve I will discuss the patient in the MDT definitely, and then I will involve my oncology colleague about the possible benefit from radiotherapy, and also I involve the neurosurgeon in case he needs some fixation of the spine.
All right. So two things to add. Always say that we will immediately give LHRH antagonist or start LHRH antagonist. And and if it is not available, we can always go for the orchidectomy. And one of the suggestions that I got during my preparation was whenever there are ranges are there like 16 to 24, stick to one value. So we can say that I'll give him 16 milligram dexamethasone as soon as possible, followed by a short course of 60 milligram daily, while the MDT and the other treatment is planned.
Right.
I think we'll stop it now. Mr. Dhanashekharen.
Very good. That's very comprehensive discussion of intermediate and high risk prostate cancer. The only other thing which I will add is to use the Bow's information leaflet whenever you are counseling a patient for radical prostatectomy. And sometimes there will be questions on the difference between open and robotic assisted prostatectomy. There is no big oncological outcome difference, but the main difference is in the hemoglobin loss, pain, and the hospital stay, in those aspects only. Ahmed, what do you think? Anything you want to add?
It was a wonderful session. Thank you very much. And I am happy with the depth of information and everything. It added a lot to my preparation. Thank you very much for both of you.
Very good. And since this time Anish has provided me the slides, I've tried to incorporate the slides into the YouTube. So when you are reviewing your presentation in the YouTube channel, you can see it is nicely backed up with the slides also. Okay.
Can I ask something about the castration resistant to prostate cancer or the sting of castration-resistant prostate cancer, or in the case of a newly diagnosed metastatic hormone-sensitive prostate cancer? Is there any preference or guideline to start docetaxel first and then abiraterone and enzalutamide, or we can start with abiraterone? Is there any factors to mind with which one we should start?
Yeah, because there are lots of studies. All these medications started in the scenario of CRPC. But then Stampede and started docetaxel in the scenario of hormone-sensitive prostate cancer, and now it has gone into the scenario of even non-metastatic prostate cancer, like a locally advanced prostate cancer. So it all depends on if you go through the AUA, there are index patients available, like 16 index patients, and the good thing is that if it is a locally advanced prostate cancer, and if you start him on docetaxel, when he reaches to the level of CRPC, the option is to try the other medication. It will be like if the patient hasn't had docetaxel before, go for docetaxel. If the patient has had docetaxel or cabazitaxel before, go for the newer ones.
Yeah. And my understanding that is also the performance and the kidney function. So if the performance is good,
Exactly.
If kidney function is good, maybe we start with docetaxel. If not, we start with abiraterone and enzalutamide.
Exactly. Yeah, exactly. And also there are other things that we have to discuss, possibly because it's almost nearing 1 hour, that's why. But we will discuss that CRPC as a scenario in 10 minutes. And we have to discuss the bisphosphonates, the role of denosumab, the role of radium-223. So that will take almost 2 to 3 minutes of discussion. But we will, because I thought it's today we should concentrate mainly on the locally advanced and the initial metastatic, but CRPC in itself, it could be a potential clinical scenario. I'm not aware of anyone who is asked completely about CRPC only, possibly because it is in the realm of oncologists now. But it's always better to prepare well, so that even if you are faced with that question in the exam, it will be easier for you to sail on.
Yeah, absolutely fine. Thank you very much.
Very good. Thank you. That's a very useful resource for revision and for other students. Thank you, and have a good rest of the day for both of you.
Thank you very much.
Excellent session. Thank you. Thank you. Great.